Ladies and gentlemen, IDE Henry here to present ectopic pregnancy. Alright, so I received a comment in the comment section that I should do this condition. So let's quickly look at a question so that we do ectopic pregnancy. Alright. So our question here is, Miss Luita, a 25-year-old woman, comes to your gynecological ward with complaints of severe lower abdominal pains and the diagnosis of ruptured ectopic pregnancy is made. Question A. Define the following terms. A. Ectopic pregnancy. B. Salpingitis. Question B. State 5 signs and symptoms of ruptured ectopic pregnancy. And C. Discuss the pre-operative care of Miss Luita until discharge. Lastly, draw a well-labeled diagram indicating the 5 possible sites of ectopic pregnancy. Let's begin. My definition of ectopic pregnancy is a complication of pregnancy in which a fertilized ovum does not reach the uterus but becomes caught and implanted on any tissue other than the lining of the uterus. An ectopic pregnancy is a complication of pregnancy in which the fertilized ovum does not reach the cavity of the uterus, but becomes caught and implanted in any tissue other than the lining of the uterine cavity. Our second definition was that of salpingitis, and our definition is salpingitis is a medical term that refers to the inflammation of the fallopian tubes, which are the ducts that connect the ovaries to the uterus in females, caused by a bacterial infection, most commonly from sexually transmitted diseases such as gonorrhea or chlamydia. Alright, so this is how we can define ectopic pregnancy and salpingitis. Our next question reads, the signs and symptoms. We are required to write 5 signs and symptoms, and of which the first one is sudden sharp abdominal pain. This one is usually located on one side of the abdomen and may be accompanied by nausea, vomiting, and dizziness. Also, we have heavy bleeding. The bleeding may be bright red or dark brown, and it may be accompanied by clots. Alright? Also, low blood pressure. This is a sign that the body is losing blood, and this happens due to continuous bleeding from the ruptured pregnancy. We also have shock. This is a life-threatening condition in which, when the body does not have enough blood flow, symptoms of shock include pale skin, clammy skin, rapid breathing, and lastly, confusion. Having looked at that, ladies and gentlemen, the last sign and symptom is that of shoulder pain. This pain is caused by blood leaking into the space between the lungs and the chest wall. Hence, there's going to be a pain called referred pain. Alright. Let's quickly dive into the management. This is an emergency, ladies and gentlemen. Ruptured ectopic pregnancy is a gynecological and surgical emergency. So our aims are to resuscitate the woman and to prepare the woman for emergency surgery. Having said that, let us quickly dive into resuscitation. Primary resuscitation or primary assessment and resuscitation. Firstly, I will assess the patient's airway for foreign objects, for secretions, to observe patency, and if there are any, I am going to suction them using a suctioning machine. And also, breathing, I will observe and monitor the breath rate of the patient, and if the breath rate is above normal, which is tachypnea, or below normal, which is bradypnea, I am going to reposition the patient in propped up position to promote lung expansion, and I'm going to initiate humidified oxygen. We go to C, where most of the work is. So, under circulation, you're going to say the following things. I will establish an IV access for administration of fluids and transfusion of blood. I will collect blood for HB, grouping and cross-match in readiness for blood transfusion. I will administer pethidine 50 milligrams intramuscularly to reduce pain. And then, other components of resuscitation, you can talk about urinary catheter insertion to prevent a full bladder during the operation and the like. And then, having said that, you can also talk about D, which is degree of consciousness, using a Glasgow Coma scale. I will monitor and ascertain the level of consciousness. If the Glasgow Coma scale is below 13, I will take the patient to ICU. But if not, the patient stays in the ward. Having resuscitated our patient, ladies and gentlemen, let us quickly go to the environment. Under environment, you can mention the following things: the ward, area of admission, equipment around the patient's bed, as well as cleanliness of the environment and quietness. Ward, the patient is nursed in, or I will nurse the patient in gyne ward. I will admit the patient in gyne ward for specialized gynecological care. Secondly, I will nurse the patient in acute bay for close monitoring and observations. Thirdly, I will mobilize the following equipment around the patient's bed, namely a drip stand for fluid administration, an oxygen cylinder for oxygen administration, a TPR tray for continuous monitoring of vital signs, a working suctioning machine for suctioning of secretions. With that said, ladies and gentlemen, we can now include the last point, which is cleanliness of the environment. I would dust all surfaces to nurse the patient in a clean environment. The environment will be well lit. The environment will be well ventilated. With that said, let us quickly dive to psychological care. So under psychological care, you can mention the following things. Firstly, I will explain the condition to the patient in simple terms for her to understand. All right. I will explain the procedures done on the patient to allay anxiety and promote cooperation. Thirdly, I will encourage the patient and her partner to express feelings of fear, loss, and grief. And also, I will encourage the patient to ask questions, and I will answer them appropriately and refer difficult questions to the physician. And also, I will explain to the patient that the healthcare team is doing its very best possible to ensure that the patient is well again. And lastly, I will help the patient develop coping strategies such as relaxation techniques, for example, deep breathing exercises to manage stress and keep calm. Having done that, ladies and gentlemen, we quickly go to observations. What do we observe? We are going to observe A, B, C, D. We're going to observe the airway, breathing, and circulation. Just a quick assessment on these to note any deviations. Secondly, I will observe vital signs of the patient. Vital signs being, number 1, temperature as a separate sentence. Temperature, to note any rise or fall, to note hypothermia or hyperthermia. I will monitor the pulse rate of the patient, radio pulse to be specific, to note tachycardia or bradycardia, which will be indicative of cardiovascular abnormalities. And then you're going to monitor the respirations, if they're above normal or below normal, to ascertain if the patient is in respiratory distress. And also, you can mention that I will check the blood pressure of the patient to note if the patient is hypotensive or the patient is hypertensive. This is going to show also any cardiovascular abnormalities. Having done that, ladies and gentlemen, you can also observe facial expressions for pain, all right? You can observe for vaginal bleeding to a certain amount, all right? And also, you can observe the general condition of the patient. You can also observe the level of consciousness. Having done that, ladies and gentlemen, the next heading is that of pain management. Remember, ruptured ectopic pregnancy is very painful. Since there's acute pain, you're going to administer, because in your resuscitation, you gave pethidine. So we can now wean off pethidine, and we can reposition the patient for comfort. We can provide diversional therapy. We can also administer a mild analgesia such as diclofenac intramuscular injection to relieve pain. Having done that, we go to consent for surgery. All right. So if the patient is scheduled for surgery, which in this case is surgery such as laparotomy or oophorectomy, salpingectomy, you can request for her to sign the consent form. So I will explain to the patient the type of surgery she's going for and what to expect. And also, I will ask her and explain to her the importance of the consent form. Lastly, I will ask the patient to sign the consent form in the presence of a witness. The witness can be the partner, and the witness can be another staff member. With that said, ladies and gentlemen, the next is cardinal control tests. Under this heading, you can explain the following points. I will collect blood for hemoglobin count to rule out anemia. The blood will be used for grouping and cross-matching, and also blood will be collected for bedside clotting time, so that we know how much time it will take for the patient's blood to clot, and if the patient has got any clotting deficiency or bleeding tendencies. Having done the cardinal control tests, ladies and gentlemen, we quickly go to nutrition. The patient has come for emergency surgery. If the patient had anything in the last 3 to 6 hours, I am going to insert an nasogastric tube and evacuate the content by gastric lavage. If not, I will advise the patient to be new orally until the surgery. All right. With that being done, ladies and gentlemen, we quickly now go to elimination. You're going to catheterize the patient. You're going to encourage the patient to open bowels. You're going to encourage the patient to urinate. With that said, ladies and gentlemen, we quickly go to immediate preparations. So under immediate preparations, you're going to mention the following things. So I am going to shave or trim the patient's hair in the perineum and the upper pelvic region. Following hospital policy, you will provide privacy whilst consent from the patient. And then I will gown the patient, and also I will label the patient using a band, including the name, the age, and the type of surgery that the patient is going for. I will remove any dentures or prosthetics, as these may electrocute the patient or may choke the patient in case of use of a diathermy machine. I will remove nail polish to enable the surgeons during the operation to monitor capillary refill time. And also, with that said, ladies and gentlemen, we're done with the immediate preparations. And then we now talk about pre-medication. So because the patient is not going to sleep, we're going to give atropine sulfate to reduce secretions prior to surgery. And also, we're going to administer Valium. Now, Valium was going to be administered if the patient was going for an elective surgery. In an emergency, no Valium. So that's the pre-medication we're going to give. Having said that, we go to transfer of patient to theater. Under transfer of patient to theater, you mention the following things. I will transfer the patient to theater using a stretcher with rails to prevent falls. Number 2, I will walk by the head side of the patient while observing and giving continuous reassurance, pushing the trolley. The porter, on the other hand, will walk on the foot end of the trolley, pulling the trolley on the way to theater. With that said, ladies and gentlemen, we now talk about giving handover to the theater nurse. So, whilst transferring the patient, you will have collected, whilst you transfer of the patient, you will have collected the patient's file. So, I will give handover to the theater nurse on the patient's name, the age, the diagnosis, latest vital signs, and the type of surgery that the patient is going for. All right. With that said, you're now going to prepare a post-operative bed. When you prepare a post-operative bed, you're going to mobilize the following: a post-operative tray. You're going to make a post-operative bed. You're going to immobilize a drip stand, an oxygen cylinder. You're going to have a sphygmomanometer, a thermometer. You're also going to have gloves, cannula, needles, medication, and the like. A tongue forceps, a mouth spatula, and also a mouth gag. With that said, ladies and gentlemen, this is how you write the preoperative management for a patient going for emergency surgery after a ruptured ectopic pregnancy. We proceed to the next question. And the next question is sites for ectopic pregnancy. So we have the following. Starting from the most inferior, we have the cervical ectopic pregnancy. We have the vaginal ectopic pregnancy. We also have the cervical ectopic pregnancy. We have the utero ectopic pregnancy in the interstitial space. So I'll start again. Vaginal ectopic pregnancy, cervical ectopic pregnancy, interstitial ectopic pregnancy, fallopian, and this one is the isthmus. So isthmo or isthmic ectopic pregnancy. We also have cone wall ectopic pregnancy, ampullary, and ovarian, even abdominal. Let us look at the percentages of each type of ectopic pregnancy. So interstitial portion accounts for 2% of all ectopic pregnancies. The isthmo is also known as tubal pregnancy, accounts for 25%. The ampulla or ampullary ectopic pregnancy accounts for 55%. Then infundibular or fimbriated, that is one that occurs at the site of the ovaries. Yes, at the site of the ovaries. This type of ectopic pregnancy accounts for 2%. Ovarian accounts for 0.5%. And lastly, abdominal ectopic pregnancy, which accounts for 0.1%. With that done, ladies and gentlemen, this brings us to the end of our presentation. We have done ectopic pregnancy, and we have done the sites, we have done the preoperative management, and we have also done the signs and symptoms. We have defined it. We have also defined salpingitis. So please subscribe to my channel, and if you want me to create more content like this, just leave a comment in the comment section, and I'll surely drop a video on the topic on whose management you would like me to help with. For now,